So as to understand fully the ramifications we see with double inlet ventricle, we're going to have to combine the connections at atrioventricular level with those at ventricular arterial level. But we need to start by emphasizing that double inlet ventricle is simply one form of univentricular atrioventricular connection. And over the years, this has probably been the lesion, certainly as far as I'm concerned, that has produced the most trouble in description and has related to the greatest degree of controversy. And that is because hardly ever do we see double inlet ventricle in the setting of an anatomically univentricular heart. And it is probably still the univentricular heart that creates the greatest problems in description. But if we accept that always double inlet ventricle creates a functionally univentricular pattern, then I think we can solve both the anatomic problems and the descriptive problems, because simply adding the adverb functionally makes everything logical. So within our functionally univentricular pattern, we need to take account of the morphologic variations in terms of what's happening at ventricular level, what's happening at atrioventricular valvar level, the position of an incomplete ventricle when such an incomplete ventricle is present, and then looking at the ventricular arterial junctions and not fitting the associated malformations. So let me take you through again what we mean by univentricular atrioventricular connection. And you've seen all these pictures once, so we can be relatively swift, because you know now that we can have univentricular atrioventricular connection with any atrial arrangement, although we're going to show you for the most part in the setting of usual atrial arrangement, but it can exist when the atrial chambers are mirror imaged. And in fact, it's quite frequent to find univentricular connections in the setting of right isomerism, and we can also find them in the setting of left isomerism. But at this time, we're concerned mostly with double inlet ventricle. And double inlet ventricle is the paradigm of the univentricular atrioventricular connection, in that both atrioventricular junctions join to only one ventricle. But as you've already heard, we can have the same situation when either the right connection is absent or when the left connection is absent. And then with either of those connections, as we've heard just a few moments ago, we can have concordant or discordant connections across the solitary atrioventricular junction. But at this stage, we are concerned with ventricular morphology, and we're looking at it in the setting of double inlet left ventricle here. And what we see is that both segments of atrial myocardium join to a big ventricle that has fine apical trabeculations, and then the incomplete small ventricle is of right ventricular morphology. But you will appreciate that we can have the same double inlet connection when it is the right ventricle that is dominant and the left ventricle that is incomplete and rudimentary, and exceedingly rarely there can truly be a solitary chamber within the ventricular mass, and that has particularly coarse apical trabeculations. And now we're going to concentrate on what's happening at the ventricular arterial junctions. So to repeat, the variations in terms of ventricular morphology: dominant left ventricle with incomplete right ventricle, dominant right ventricle with incomplete left ventricle, rarely solitary and indeterminate ventricle. And in this context, it's also important to distinguish these double inlets from the also rare situation in which the atrioventricular connections are concordant or discordant, but the ventricular septum is hugely deficient, so we have a monster ventricular septal defect. You will all recognize now, I hope, the essence of double inlet left ventricle, because here we have simulated the echocardiographic four-chamber cut to show you that when we have a big ventricle with fine crisscrossing apical trabeculations, the essence of double inlet is that the right atrial myocardium and the left atrial myocardium are connected in their greater part to the big ventricle. And in the picture you're looking at the moment, this is being done through two atrioventricular valves. But as I will show you, you can also have double inlet left ventricle through a common atrioventricular valve. Now when we see it in the posterior four-chamber cut, as shown at the moment, you might think that there is only one ventricle. But you are all well aware that when you turn your attention anterosuperiorly within the ventricular mass, in such settings we find the second ventricular chamber. And it is the nature of this second ventricular chamber that still creates problems. There are those who still maintain that this is no more than an infundibulum. But you can immediately see that that is not the case, because unequivocally this is an incomplete right ventricle. Why is it an incomplete right ventricle? Because it possesses the apical part that is of right ventricular morphology. And moreover, the septum separating this apical part from the dominant ventricle carries the conduction tissue, showing that it is an incomplete ventricular septum, and it is nourished by the septal perforating arteries. It is not an infundibulum. In fact, here is the infundibulum. The infundibulum is the muscular sleeve supporting the outlet to, in this instance, the aortic valve. So there is no question but this second chamber is an incomplete right ventricle, and that the heart as a whole is not anatomically univentricular. It has one big and one small ventricle, but unequivocally functionally univentricular. So the key feature in differentiating types of double inlet left ventricle is the position of that incomplete right ventricle. Always it is anterosuperiorly located on the shoulders of the ventricular mass, but it can be left-sided, as you see here, or it can be right-sided, as you see here. And in this instance we can infer that this is the consequence of leftward looping or left-hand topology. We can infer that this is the consequence of rightward looping or right-hand topology. But as you see, when we lack a ventricular inlet, you can get the palmar surface of either hand on either of these ventricles with the thumb, the fingers up the outlet. So strictly you cannot determine ventricular topology in the setting of double inlet left ventricle. But we can infer that when the incomplete right ventricle has gone left, this is indicative of left-hand topology. When it's gone right, it's indicative of right-hand topology. And the hole between the chambers is no more and no less ventricular septal defect. So let's look at double inlet right ventricle. It was hearts of this type that we described in our paper in 1979 that created all the problems and gave rise to the morphological method. So what you see here, again in a simulated four-chamber section, is that both the right atrioventricular valve, the left atrioventricular valve are connected in their greater part to a big ventricle that has coarse apical trabeculations, telling us that almost certainly this is a right ventricle. But we can confirm that it is a right ventricle when we look behind this atrioventricular valve, postero-inferiorly within the ventricular mass, in the left hip pocket, and we see unequivocally that there is a second chamber having fine apical trabeculations, an incomplete left ventricle lacking its outlet component because there is double outlet from the dominant right ventricle, and also lacking the larger part of the inlet, albeit that one papillary muscle remains in the incomplete left ventricle. But no question that we are dealing here with double inlet right ventricle, incomplete left ventricle. And as I've shown you, rarely that incomplete left ventricle can be right-sided, but is still positioned inferiorly within the ventricular mass. So you know the answer to this question. We can have truly solitary ventricles. They are as rare as hen's teeth. This is the example from the Brompton Hospital, where there is double inlet to a chamber with exceedingly coarse trabeculations, double outlet. We looked everywhere for a second chamber. We couldn't find one. The only septal structure is the muscular outlet septum, and this is solitary and indeterminate ventricle. We can also distinguish huge ventricular septal defects because we find that the tricuspid valve enters the apical part of a ventricular mass that has right ventricular trabeculations, and the mitral valve enters the apical part that has left ventricular trabeculations. And here is a shelf that is separating those two apical trabeculations. The rest of the septum is deficient. You see that it is spanned by the septomarginal trabeculation, and the septomarginal trabeculation carries the conduction system, telling us that this is a huge ventricular septal defect. And obviously, the surgeon trying to repair this or septate this would need to take great care with that muscular strand, but this can potentially be turned into a ventricular arrangement. So the atrioventricular valves, usually there are two, but the presence of a common valve does not alter the fact that the junctional arrangement is that of double inlet. When we have two valves, one can be infiltrate or one can be straddling. So here you see the typical situation with double inlet ventricle opened in clam-like fashion, showing you the two atrioventricular valves. But here in another situation, we have a common atrioventricular junction connected in its entirety to the dominant ventricle, double inlet ventricle, through a common ventricular valve. Here is straddling of the right atrioventricular valve, in this instance with the larger part of the straddling valve going to the right ventricle, the left ventricle rather, meaning we have a functionally univentricular arrangement. But as I have already emphasized to you, with straddling and overriding of the tricuspid valve and septal malalignment, we can have the situation in which the valve is committed mostly to the right ventricle, giving us potentially a biventricular arrangement, albeit that surgery to create such a biventricular arrangement is still remarkably difficult. But remember that the ventricular arterial connections can markedly change. So in most instances when we have double inlet left ventricle, the ventricular arterial connections are discordant. But they can be concordant, and that is the entity usually described as the Holmes heart. And there rarely can be double outlet from the incomplete right ventricle, and I fancy that is probably what Leo was asking about yesterday when he mentioned double outlet infundibulum, because in Boston they still think that the incomplete right ventricle is no more than an infundibulum. And you can also have single outlet. When we have right ventricle, almost always there is double outlet from the dominant chamber, and of course with solitary or indeterminate ventricle there can only be double outlet or single outlet. Simply there is a solitary ventricular chamber. So this is the picture I've shown you already with discordant ventricular arterial connections, and then the infundibulum is relatively short. This is the arrangement we see in the so-called Holmes heart, and when you only look at the incomplete right ventricle, it is not possible to tell whether this patient has double inlet left ventricle or tricuspid atresia, because in concordant ventricular arterial connections we have this added length of the subpulmonary infundibulum. And here is the heart, the main dominant ventricle of a heart I've shown you already. This is the dominant left ventricle, which receives both atrioventricular valves, gives rise to both arterial trunks. And if the Bostonians were correct, and if that chamber were only an infundibulum, then in this heart there'd be no room for anything else. Whereas, as I've shown you already, on the rightward and anterior shoulder of this ventricular mass, we have an obvious apical trabecular component of right ventricular type, confirming that the second chamber is an incomplete right ventricle, separated from the dominant ventricle by the septum. And then, with dominant right ventricle, we know that the septum is postero-inferior. And indeed, oftentimes with dominant right ventricle, we have double outlet, as you see here from the big ventricle. But it is the position of the septum that permits us to distinguish the various types of double inlet ventricle, because the septum is anterior when the left ventricle is dominant, posterior when the right ventricle is dominant, and absent with solitary ventricle. It is, of course, intermediate when one or other of the valves straddles. It is important because it tells us where the conduction axis is going to be. So here again is double inlet left ventricle, shown to you by slicing off the apical component of the septum. And you see that the right ventricle is in front of the septum, the dominant left ventricle with both AV valves is behind the septum. And that dictates that the conduction axis, which you see here in green, arises, as in congenitally corrected transposition, from an anterior atrioventricular node. And the surgeons, when they tried to septate such hearts in the years gone past, they still try to do this in Japan. They know that if they're going to leave the pulmonary trunk connected to the right AV valve, the ventricular septal defect to the left AV valve, they have to cross the conduction axis. So when they were doing septation procedures, often they would deviate the suture line to create double outlet from the left half of the dominant ventricle, and then place a conduit from the right half of the pulmonary trunk. Should the interventricular communication or the ventricular septal defect become restrictive, then it can safely be enlarged. And Christopher Lincoln, when he worked at the Brompton Hospital, produced a large series of patients where he safely enlarged this tiny hole. I'm showing you here the incomplete right ventricle as it might be seen by the surgeon, with its apical part to our right hand, the tightly restrictive ventricular septal defect, and we know that the conduction axis is carried on the crest of the ventricular septum, arising from an anterolateral node within the morphologically right atrium. And the safe area for resection is that closest to the obtuse margin of the ventricular mass. And restrictive defects can be resected in this fashion without damaging the conduction axis.